Ladies and gentlemen, welcome aboard the Pilot Lawyer Podcast. Thank you for your attention while this important legal information is reviewed. What you hear should not replace consultation with an attorney and should not be considered advice for your situation. On behalf of the Pilot Lawyer and your entire crew, it's our pleasure to have you aboard.
Welcome, aviators, to the Pilot Lawyer Podcast with us, the Eisen Brothers, at the Eisen Law Firm, where aviation law is all we do, nothing else. You're here for what we do best, navigating the FAA medical certification process for pilots and those who want to become pilots. And, of course, as we say around the office, if you don't laugh, you cry. And for the next 30 minutes, we hope to bring you the lighter side of what can otherwise be a frustrating process. So, whether you're laughing at us or with us, join us, brothers, as we discuss the fascinating world of FAA medical certification.
What do you know about the lighter side of anything?
Not much.
You don't look like you do.
Yeah, my BMI tells me otherwise.
You look like you have obstructive sleep apnea.
I can tell by looking at you. Well, let me say this much. We have a special guest to talk just about
Another
that.
one?
That's right. That's right. People are sick and tired.
4 in a row.
People are sick
Come on.
People are sick and... Would you stop? People are sick and tired of hearing us. They want to talk to somebody else, hear about somebody else. So we're going to use this platform.
You sound like you're on 1.5 speed right now.
Well, yeah. We'll talk about that at another episode. Nevertheless, we have a very special guest today, Dr. Clayton Cowl. Dr. Clayton Cowl is a commercially rated pilot and a senior FAA aviation medical examiner at the Mayo Clinic in Rochester, Minnesota.
And some credentials.
That's right.
Yeah.
He served as the chair of the Division of Preventative, Occupational, and Aerospace Medicine at Mayo Clinic till January of 2022. And he holds a joint appointment in the Division of Pulmonary and Critical Care Medicine. He's a past president of the American College of Chest Physicians, as well as prior president of the Civil Aviation Medical Association, for which the aviation law firm, the Eisen Law Firm, is a sponsor. Couldn't even remember the name of our own firm there for a second. Jeez. So, fortunately, Dr. Cowl has agreed to come down to our level and explain to us, that's right, you're making our own sound effects now. He's on a podcast where people are making whistle noises.
That's a big boon for us. And
That's right.
Yeah.
That's right. So, he's going to talk to us today about obstructive sleep apnea. What a terrible condition when it comes to FAA medical certification.
Not to be
Terrible
flippant about it,
Or not.
Don't you dare.
but it is certainly an issue that the FAA is going to take
Issue
with.
That's right. That's right. So, well, let's see if Dr. Cowl is willing to answer the call. Go ahead and say your joke. It's always, are they going to answer the call? Anyhow, we're going to see if he's going to answer the call. If he does, great.
I doubt it.
If not,
Next time you need to script this out a little bit.
well, sure. All right, let's see if we can get him on.
Hello.
Hi, this is Dr. Cowl.
Yes, it is.
This is Anthony Eisen from the Eisen Law Firm. How are you?
Hey, doing well. Thank you.
Yeah, that's great. Well, hey, we already hit the record button, so we're off to the races if that's all right with you.
That's fine with me.
Well, very good. Well, I got Christopher, my brother, and Alex, my brother, here on the podcast
When
with
am
us.
I, Anthony?
Yeah. So, well, thank you so much for joining us today, Dr. Cowl. What we've been doing with the few guests we've had on so far, we've started by having them introduce themselves and telling us what they do and where they do it.
And we want to make sure that we're getting your name right as well. We understand it's Cowl, not Cowl, correct?
So that's correct. So you think of it like a bowl and put a C instead of a B.
Hey, we can do that.
There we go.
Yeah.
Okay.
So what do I do and where do I do it? Now, that's kind of a loaded question, but my day job anyway is at Mayo Clinic at the mothership, so to speak, up in Rochester, Minnesota.
Oh, nice.
And so I have a joint appointment. So not only do I take care of pilots in our what's called section of transportation medicine, but I'm also a pulmonologist. So I also take care of people with lung problems, and that is in the division of pulmonary and critical care. So with the joint appointment, you leave your keys on one desk and take off for the day, and they think you're at the other area, and then you just do vice versa. So, no, just kidding.
Well, that's cool. And so as far as what you do in the aviation sector, so you're an aviation medical examiner, is that right?
Yeah, I've been a senior AME for probably 25 years now.
Okay.
And so since I'm a bit of the old dog here, I tend to get all of the most complex cases. So it is extremely rare for me to see a healthy 18 to 22-year-old, wanting to go off to flight school. That's usually my colleagues that get those. And if you ever remember watching the Rudolph the Red-Nosed Reindeer cartoon back in kid days, or you bring your kids in now to watch it, it's the island of misfit toys here for pilots.
Hey, well, we still watch Rudolph. The level we're on.
The abominable snowman, and then all the toys like the kite that's scared of heights, and the Jack in the Box with no Jack, and so we have pilots with 2 heads and cancer. So there you have it.
Well, wow. Well, getting out of medical, that's going to be impressive. Well, Dr. Cowl, so I think we've got a general idea that you seem to see all spectrums of medical conditions with respect to aviation concerns. What we're here for today, especially, is your interest in pulmonology, and from our initial discussions, we understand that could be a wide range of conditions, from asthma to any other COPD, obstructive sleep apnea. But today we're here we probably have you back from one of those other conditions, but certainly. Today, we wanted to talk to you about obstructive sleep apnea, because that's an issue we see a lot in our practice for our clients and potential clients and so on. So would you mind kind of walking us through what OSA, or obstructive sleep apnea, actually is?
Sure. Yeah. So it's obviously it's a very common condition, which is why it's important to review it. And I think that we went through a period kind of about circa 2005 where the FAA had originally come out and said that, if you were above a certain weight or had a certain neck size, everyone would, have to, stop, do not pass go, send in all your stuff, blah, blah, blah. And then there was a huge amount of pushback by a variety of the ABC groups. So they went back to the drawing board, looked at the data that were available out there, and in credit to them, agreed that, okay, look, we don't have to, have people stand down unless it's so severe, they're basically falling asleep in the office.
Sure.
And so let's talk a little bit about what OSA is and how the certification part has evolved over time. So first of all, sleep apnea. So a lot of people are like, well, what's an apnea? And an apnea just means a stop breathing episode. Mm-hmm. Typically, we're talking about an episode that's, up to 10 seconds in duration. A partial stop breathing episode is called a hypopnea. And so there are various indices or index formats that can be used to determine how severe someone's sleep apnea is. Most people who have sleep apnea, and of course the most common being obstructive, there are other forms of sleep apnea like central apneas and other more esoteric forms, but the most common being obstructive sleep apnea. Usually the person that has it is the last one to know. Usually they're someone is kind of pushing them to go see someone, typically a bed partner. I've had pilots that where my co-pilot told me that when I was back in the when they were flying overseas or whatever and they were off duty, that we were shaking the plane with my snoring,
Right.
so that we kind of know there might exactly there might be some clue that something's not a bit amiss. But anyway, and so the idea is with obstructive sleep apnea, if you have there's obviously mild, moderate, and severe forms of obstructive sleep apnea. The FAA is probably most concerned about moderate to severe sleep apnea for the obvious reasons that over time you can become more and more sleep deprived, and we can talk a little bit about kind of the physiology of why people would get sleep deprived. And then there's all these downstream effects that happen with more severe sleep apnea, such as issues with the heart. So specifically pulmonary artery hypertension, which is increased sort of back pressure on the vessels, bringing blood low in oxygen from the right side of the heart up into the lungs. So, and then hypertension, meaning just high blood pressure. An interesting fact is that in about half of individuals with hypertension, they have undiagnosed sleep apnea and vice versa. So half of people with sleep apnea often have hypertension that hasn't been diagnosed or adequately treated. And so we can talk a little bit about why the FAA cares, besides just the fact that you can get sleepy.
Right. And that's one of the questions we get asked a lot by even clients that have sleep apnea or maybe being treated with CPAP or whatever, which is to say, why is the FAA making such a big deal about this? How is this going to affect me while I'm flying? Short of, I might fall asleep. So can you kind of walk us through how it could cause a problem when someone's flying?
Sure. So, obviously the risk of in-flight incapacitation is low, unless, you're talking about someone with, very severe or severe sleep apnea where it's been untreated and they're in a situation where they may have been a bit sleep deprived just from scheduling. You combine that with underlying untreated or suboptimally treated sleep apnea, and it's a setup. I don't know if you remember, there were a couple of Northwest Airlines pilots back in the day that overflew Minneapolis by a couple hundred miles, and the comeback was, we were having a deep discussion about the Delta merger, and I think what was finally determined was they were examining the backside of their eyelids. So it can happen. And obviously, if you're talking about long haul, cargo transport flights across the Pacific or any of the big ponds, you can get into a point where things are relatively monotonous. And, at that point, if you are already a bit sleep deprived, it can be worse. So you probably ask the question, but the people I see, they say they go to bed and they're in bed for 8 hours. Well, what's going on? And physiologically what happens is that there's 4 stages of sleep, stage 1, 2, 3, and 4. And then there's what's called REM sleep, rapid eye movement sleep. And as you get into like stage 3 and 4, which is kind of the Energizer Bunny, where you kind of reboot everything and really get refreshing sleep. When you get into that very deep restorative sleep, it's sort of, your body is sort of essentially paralyzed with the exception of your diaphragm, which of course are those sort of thin domed muscles at the base of your lungs that move to help move air, and those rapid eye movements. And those, you probably are aware, have been associated with a lot of our dream sleep. So it's REM sleep. Well, what happens is when you get into that deep restorative sleep or attempt to get into it, your body relaxes. And if you happen to have an anatomy that is such that, say, for example, you have a short jaw called a retrognathic jaw, or you are overweight and, say, have a lot of soft tissue in the neck region itself, as you relax, you develop an apnea or stop breathing episode. And, the good thing about it is we do have something called the medulla in the back of our brain, which is kind of like a thermostat, only instead of for temperature, like in our, furnaces at home or whatever, this has its thermostat is set for carbon dioxide. And when you stop breathing, your carbon dioxide goes up, your oxygen goes down. And then what happens is it says, I really should breathe here, when the carbon dioxide gets to a certain level. And then you sort of overbreathe. So then it's kind of like a big, deep breath. And that's a lot of times where the bed partner will hear either a loud snore or just a gasp in the night. Mm-hmm. And what the body's doing is trying to blow the carbon dioxide down and put get the oxygen back up again. So you have that safety net that, your brain will not let you, quote unquote, die in your sleep from that. But so what happens though is that it bumps you out of that deep restorative sleep So you're sort of in that stage 1 or 2. It's kind of like taking a cat nap on a subway. Only the problem is when you multiply that over night after night after night, you're, pulling the college all-nighter like every night, and you start feeling horrible. You get headaches. Some people get nausea. People just, they say, well, I just don't feel like my old self. If there's something in the afternoon that's, where it's a quiet time, boom, they're asleep right away. And so that's what the FAA worries about. Now, beyond that, there's, we mentioned those downstream effects, and that would be things like if you have higher blood pressures, which are often seen, like I remember I said 50% of people with OSA have undiagnosed hypertension. If you tend to have difficult to treat hypertension, it also places you at higher risk for things like atrial fibrillation and vice versa. So what happens sometimes, people will, develop atrial fibrillation, and, usually, their cardiologist may do a good history. It could be attributed to any number of things, from stimulants like, excess caffeine, this, that, and the other, to alcohol use, to a variety of other things. But then the other thing is if you're chronically hypertensive, it also sets you up for developing atrial fibrillation. So then it kind of is like a bucket brigade. They have you go back and say, okay, well, are they hypertensive? Do they have obstructive sleep apnea? So if they fit a, sort of a poster child moment there of potentially having obstructive sleep apnea, they want people to, do what's called, say, an overnight oximetry. Now, not a sleep study necessarily, just an overnight oximetry where a little oxygen probe is put on the finger. They watch, it's recording through the night. And if you have oxygen levels that are oscillating up and down all night, but kind of every 2 to 3 hours it gets worse, like during that REM sleep we were talking about, that's sort of the pathognomonic aha moment that probably is sleep apnea. Can't diagnose sleep apnea. You actually have to go, either you can get a home sleep study now, which are much more common than they were, especially in the last 5 years. But in certain people that have complications like heart-related stuff, they actually need to get a sleep study in a laboratory and sleep overnight in the lab and have that sleep study done.
Well, Dr. Cowl, this is Chris Eisen, and we really appreciate that in-depth analysis.
Especially coming from 3 guys with excess tissue around their necks.
I was like, are you looking at a picture of me?
Yeah. You must have looked at us on the website, because I guarantee you, each one of us just looking at us has sleep apnea.
Chubby guys.
But,
it's a good point. The other thing that I think is important to bring out is that sleep apnea is not only people, say, that have elevated body mass index or say overweight or fit some sort of stereotype. There are individuals that can have sleep apnea that don't necessarily, that are appropriate weight, for example, but say they have a jaw that's short, that I mentioned, that retrognathic jaw and that type of thing. And so it's important that even, if you develop symptoms that are associated with that, with sleep apnea, to not just think, well, I'm not the, 400-pound guy, so I must not have it.
We're not that big. I don't think.
We haven't gotten quite there.
No.
Well, let's say, for example, an airman comes in for an exam and you suspect that he might have obstructive sleep apnea, and they're not already on a special issuance for obstructive sleep apnea. What would happen at that point?
Well, so if they're falling asleep in the lobby or in the exam room, I think they have sleep apnea, that would probably be the only case where we would be required to defer that. So if you're a pilot out there and your examiner says that, well, you have sleep apnea, we have to defer, they're not correct. The only time you'd have to defer is if it's a high, the risk for high severity is very high. Now, on the FAA medical application form, on the AME side, not on the pilot side, there is a section specifically dedicated to sleep apnea. And we are granted the ability to issue on the spot, and we can either do one of several things. There's 6 options on the medical application form. One, I mentioned already, is we have to defer it, and that's only for severe cases. We can click, says something that says discuss OSA risk with airmen and provide educational material. So here it might be someone that we might suspect it, but and we don't know it, we haven't proven it, but we say, hey, here's an FAA pamphlet on that. Go talk to your doctor. We're going to issue today, but then all we do is we click that little button. Okay, so it's on the radar screen. It's not required that you get a sleep study, but the FAA may later require that at least that you visited with someone or had some sort of, initial evaluation of some type. One of the other ones is they have us look at what's called the American Academy of Sleep Medicine, or AASM, criteria to kind of lean you towards someone that has high risk for sleep apnea. And basically we can check that box that says we think they're probably severe enough, and then they're going to require at the next visit or the next flight physical that they have a sleep study have been done. The third option is they already have a diagnosis and they're on special issuance, and we're just sending the reports. We upload the reports. Or they have a sleep apnea diagnosis and it's being treated, and that they're not on special issuance, but we're going to go ahead and issue and send reports, and then they'll get a special issuance letter. So long-winded way of saying that it is rare now that a pilot would not get a medical certificate for having sleep apnea. So there's a lot of angst out there because of it,
Right.
but in reality, it really shouldn't slow them up too much at all.
Right.
Has your FAA medical certificate been denied? Are you concerned you may not be able to get a medical certificate from the FAA? Are you at risk for FAA action for failing to report your medical history appropriately? Call the pilot lawyer at 1-855-FAA-1215 to discuss your options for getting the FAA to issue your medical certificate and get you flying. We are happy to evaluate your case and discuss with you a plan for presenting your case to the AME or the FAA. Aviation law is all we do, nothing else.
Well, on our end, we'll see a lot of cases where maybe somebody's got some other issue going on, and the FAA is looking at your records and they've decided, hey, maybe we'd like more information on sleep apnea. Something we're seeing right now quite commonly is the veterans with the VA disability sort of inquiry. A lot of veterans getting VA disability benefits for obstructive sleep apnea. And so we'll see letters come from the FAA, or, after maybe you've issued the certificate and as an AME and you've selected that maybe they should receive some level of counseling or the like on obstructive sleep apnea, the FAA will send a letter and they'll ask for, maybe a sleep study or something along those lines. So the question that I'm building up here, how would an airman go about proving to the FAA that either he or she doesn't have obstructive sleep apnea or that they do have sleep apnea? What does that process look like as far as sleep studies are concerned and so on? I know you kind of already answered that.
No, that's a good question. And what it is so in terms of demonstrating that, say, you don't have sleep apnea, the easiest way to do it is to go to a sleep medicine provider. And the thing is it's not just pulmonologists that do sleep medicine, but it's psychiatrists, neurologists. It depends on what clinic or institution or hospital that it's associated with. Depends on, who's actually practicing in those areas. But regardless, a sleep disorders center, get whoever is seeing you to go through everything, document everything well, because a lot of this, keep in mind, is the FAA exam is a forensic exam. They're trying to document that you either do or don't have something because they're trying to weigh the risk. So in this particular case, if you're trying to prove that you don't have sleep apnea, if the sleep disorder specialist says, they have snoring and we've done an overnight oximetry and it's stone cold normal, which has a good negative predictive value, meaning that if it's normal, it's probably not associated with, sleep related disordered breathing. So, they can do something simple like that. and, it's just snoring, and that's fine. And the FAA doesn't care about that. If it's something where you do have sleep apnea, the main thing the FAA is looking for is that it's adequately treated. And when we say adequately treated, the most common treatment, of course, is CPAP, continuous positive airway pressure, which is sort of like a pneumatic splint that keeps that airway open when you get into deep restorative sleep at night. And the idea is that FAA would like to see pilots using it on average 75% of nights on an average of about 6 hours per night. Now, that's not a hard and fast cutoff. I mean, if it's 5 hours and something, or, and it's 72% of nights or something, they're not going to deny the renewal of a special issuance on that basis. So it's mostly they want to know that the pilot's been generally compliant. And it does require, as I think you know, that a CPAP compliance download report be included with the renewal of the special issuance.
Well, Dr. Cowl, there's presently a bunch of hand signals going on here between me, Alex, and Anthony about the next question to be asked here. And that's whether or not the FAA would accept alternative treatments beyond the CPAP with respect to, treatment of obstructive sleep apnea.
They do. The key is to be able to prove that whatever the device is, that you aren't putting it on your dog or your girlfriend. And so for example, in individuals with relatively mild obstructive sleep apnea, you can use something called an oral appliance that you probably have heard of that kind of keeps your jaw jutted forward a little bit. It's also, in some cases, called a mandibular advancement device. But that is not typically going to be effective for someone with moderate to severe obstructive sleep apnea. That'll be for mild cases. Now, the newer, when I'll say newer, in the last 5 to 7 years, those devices actually come with a chip that it can monitor that you're actually using it. It's not sitting on the nightstand collecting dust. And now they're asking, if you want to cheat the system, I'm sure that someone could cheat the system, but you're really cheating yourself. But as you probably have seen, there's those forms where you sign, yes, I wore the CPAP mask, night and date. It's at a certain point, it becomes somewhat comical, but you do what you do as on the examiner side, is have them fill out the form and make sure it gets uploaded. So
right
now there are other options besides the mandibular advancement device or an oral appliance. And I have had a pilot that is currently using the hypoglossal nerve stimulator, which is, think of it like a pacemaker for the hypoglossal nerve, which helps trigger that breathing and opening the back portion of the throat. Now, again, it's not for everyone, and it is more for, again, moderate to severe sleep apnea, but, you're putting a device, it's an indwelling device, they're inserting that in your body. Not all of them work very well, and there is potential risk, and they're a lot more expensive than CPAP. But if you're just not able to tolerate CPAP, it's an option, and the FAA has approved that. So there's a lot of different possible pathways that a pilot can go towards creating appropriate care for sleep-related disordered breathing.
Dr. Cowl, let me jump back a few steps before Christopher jumped in with his premature question here. When it comes to the sleep studies, we don't see this as much, at least in the letters we see and so on from the FAA, and probably because, I don't know why, but it seems to be there used to be a big disclaimer. We don't want a type 3 sleep study. We only want a type 1 or type 2. Can you walk us through what that is and kind of what the FAA, what to expect and when you're doing that?
So you're saying that the FAA had that in a letter?
Right. We've seen that before where they've kicked back. Somebody's done an at-home type 3 sleep study, and they didn't want that. They wanted a type 2 sleep study, for example.
I don't know about this because I fell asleep when those letters came in.
Surprised you're awake now.
So what they're referring to when they say that, I actually haven't I haven't seen one of those letters saying, what. I mean, maybe I just didn't read it. That could be.
We probably didn't either.
There's no confusion.
So a type 1 level study, or polysomnography, that's a fancy name for a sleep study, is overnight in a sleep lab or in a hospital. A type 4, there's like a type 4 home sleep test, and that only records 3 channels or 3 variables. Like, for instance, it might just record airflow, pulse and heart rate together, and oxygen saturation. And for example, a type 3 test would have a few more channels, and it would allow, you could still do it at home, but now maybe there's a channel that you can, like a little sticky that you can put by your lip, and that can measure snoring, for example. When you do a full montage, it's called, in a lab, they're also doing brainwave tests so that they can tell when you go into those various stages of sleep and record those. And, not everything that goes bump in the night is sleep apnea. I mean, there are other things like, REM-related sleep disorder where people act out dreams at night and the weird and unusual stuff. And so having a sleep study in that kind of controlled situation and not necessarily in someone's home really helps to diagnose those types of things as well. So I don't know if I really addressed your question.
That's okay. No, we live in the weird and unusual realms.
Yeah, okay. Yeah.
But that makes good sense, and that certainly answers the question. One last follow-up question, if you'll indulge me. So we'll have clients, for example, they will go and get a sleep study, and the doctor, the treating doctor, evaluating doctor will say, maybe it's mild sleep apnea. I don't think you need treatment. But then they still have this diagnosis of maybe mild obstructive sleep apnea. And so the concern for the airman typically is, will the FAA still require me to engage in some level of treatment? Is there a threshold there that you have found that the FAA is looking for as far as the results of those sleep studies are concerned?
Yeah, well, that's a good question. And one of the variables that are looked at is something called an AHI, or Apnea Hypopnea Index. It's the number of either apneas or hypopneas that we talked about before occurs every hour. And if it's above 30 is fairly significant sleep apnea. Below 5, for example, or say less than 10 is more mild sleep apnea. One test that can be done if you're trying to prove that, hey, I'm good and I don't need CPAP and I'm sort of on that borderline of needing anything, is something called a maintenance of wakefulness test, or MWT. And basically, it takes about a half a day to do. It's 4 40-minute sessions, and they basically put you in a dark room and say, don't go to sleep. Ooh. And they see how long it takes for you to go to sleep.
I almost fell asleep driving down I-4 yesterday.
Yes.
So I don't think I do well on this.
So that has, a specific, so that's an MWT is one of those tests. It's not the world's best test. Technically when you do it, you are supposed to, order, make sure people aren't juicing themselves before the, test with stimulants, and then there's a multiple sleep latency test, which is a little bit different, but we use that more to look for narcolepsy.
Sure.
We can look for narcolepsy with MWT, and that's a whole nother session for us to talk about. But if someone has a confirmed diagnosis of narcolepsy, they aren't going to be flying airplanes. It's just it's not going to happen, and it's one of those no-nos that the FAA has not opened yet.
Sure.
For pilots. But certainly they've got a lot more liberal on approving medicals for people with sleep apnea, which is a good thing.
Well, that's very good. Well, Dr. Cowl, I mean, this has all been very helpful, and
I've learned something today.
We've learned something.
Right?
I mean, I didn't know any of this before. So.
Well, and I'll tell you what, though. We've certainly enjoyed having you on. It's been a real pleasure for us, but we might need to get more info out of you. And so we understand that we understand that.
I can hear it now. So, Dr. Cole, you've won a year's supply of rice-a-roni from the San Francisco treat.
Just wait until you see what comes in the mail.
Well,
Exactly.
Well, instead of having to make you come on the podcast every week, we might call into you because we understand that Mayo offers a web-based service for pilots where they can ask aeromedical questions and get answers within a day to 2 days, called the Mayo Clinic Clear Approach. And could you tell us more about what that is?
Yeah, it's a very easy to use. It's a nominal fee. You know, if someone just picks up the phone and tries to call Section of Transportation Medicine at Mayo Clinic, you know, number one is it's, you know, getting into Fort Knox sometimes.
Sure.
And number two is there's not that opportunity for a confessional booth moment, so to speak. And so with this, it's completely, you basically create an account it's all encrypted, and it's not, none of this is shared with the FAA. We can serve as physician consultants and not necessarily because we haven't developed a relationship as an aviation medical examiner. So we can come right out and say, this would be a no-go. This, you know, you need to work on this, you know, blah, blah, blah. And you can ask a question about pretty much, well, not just pretty much, everything. So, I mean, anything that comes up that there's a question about, be it a drug, be it a certain condition, we can't, because of practicing medicine across state lines law, you know, thanks to you guys. No.
Yeah.
But we can't, for example, with atrial fibrillation, we're not going to tell you what to take for atrial fibrillation, but we certainly can tell you the process of what's going to be needed for FAA flight physicals and how to, you know, speed over the potholes that potentially can present themselves if you have someone that doesn't speak airplane taking care of you.
Well, that's an excellent service.
So that is easy to do.
That's an excellent service, and certainly, you know, here at our firm, we certainly don't work in a vacuum, and we appreciate, you know, doctors doing what they do, you guys doing what you do. That certainly is a benefit to the airmen. So we thank you for that, and certainly recommend that service to folks that are listening. But Dr. Cole, we won't waste any more of your day talking to us. So we thank you very much for your time, and sorry for any effect your appearance on here may have to your careers.
No, it'll be fine. I'd be happy to come back on. You know, the aviation community is relatively small. Mayo Clinic's been involved in it in a long time, dating back to, you know, pre-World War II era. A lot of history here in regards to things like the bailout bottle, the fly bladder G suit, you know, the BLB mask, which everyone used to have to wear when they did commercial flights because we didn't have pressurized cabins at that point. All of that was developed right here in Rochester, believe it or not. We go a long ways back here, and we have a hyperbaric and altitude facility. We've done the testing on the Boeing 787 emergency oxygen mask. So our section is sort of masked in anonymity, so to speak. Most people don't think of that stuff when they think of Mayo Clinic. So we appreciate the opportunity to get out and let people know about what we do.
Absolutely. Well, you're doing a good job, and there's as we told you, I'm sure you didn't find it organically, but we had Dr. Servin from the Mayo Clinic on our podcast in the first episode, and so a lot of good folks at Mayo for sure.
Absolutely. Well, he's lucky in that he's at the Florida campus, so he doesn't have to put up with our brutal winters.
That's true.
Yeah, but he's got brutal summers, and I can attest to that.
Yeah.
Exactly.
Well, thank you so much, and we'll probably have you back on if you're willing.
Oh, that sounds great.
All right.
You guys have a great afternoon, and keep doing what you're doing for pilots.
Well, thank you so much.
Appreciate it.
All right. Take care.
Right. Take care, guys.
Bye-bye.
Well, boys, before we turn... Boys, yeah. Before we turn base to final here.
What do you know about base to final? You're not even a pilot.
I am a sponge. I'm taking in a lot more than you think, buddy.
Let me say this much.
You know what base to final is?
Yeah.
What? Okay. Explain
Base is parallel to the runway. You turn final onto your approach to land.
Wrong. Downwind is parallel to the runway. You turn base at the 90-degree angle, and then final.
You're a moldy sponge in the sink.
You don't know.
Let me say this much though. What Dr. Cole failed to mention
It's
Was-
pretty good though. I'll give you.
He's about to put words in the mouth.
What Dr. Cowl failed to mention was individuals with babies and 2-year-olds that keep us up all night. I mean, that's prevented a rim for like 7 years. God bless them. Well, that being said, we learned a lot here today, and I think
excellent content.
There's more to learn.
Excellent.
There's more to learn. So
I want to know more about the asthma.
asthma.
Aspect.
Wait.
Well, whatever you call it.
I'm looking you right in the puss. So
You know what? That dark room test, I think I could sign up for one of those.
yeah,
That sounds nice.
you look like one.
Well, anyways, you've logged another uneventful half.
No.
It's
Another.
when the guests are on,
Right.
as a
It was
courtesy.
eventful.
As a courtesy, we say it's an eventful hour.
Okay. Well, you've logged another eventful about 45 minutes to an hour
There you go.
listening to the Pilot Lawyer podcast. Even though Dr. Servin, Dr. Dennison, Dr. Bradshaw, and now Dr. Cowl all deny that they know us in public. We are the Eisen brothers of the Eisen Law Firm. Good day.
This is thepodcastfactory.com.